and all. Hope all of you are enjoying and studying and getting some insight onto palliative care. We are slowly stepping into important sessions one by one. And as we said in the previous session, pain is a very important thing, even in your, as we all said, both me and the faculty, that 60 to 80% of your patients whom you will be seeing, you will have to deal with managing pain, and it is possible to some or to a great extent. Okay, for that, for going further into what you need to know, today you've got someone who is going to take us through the topic of management of pain. As we mentioned, pain as such, we have few sessions, okay? So a warm welcome to Dr. Parul Raina, who has done her master's in anesthesia from Jammu, and she's trained post-anesthesia from AIIMS, Delhi. And the important other thing is that she was one of the persons coming out in Flying Stars in the Global Fellowship Program too, which was the first program for Pallium India. And the main interest for her is to work with palliative care. So you need someone to take you through management of pain who has a good interest in it. So who knows the nitty-gritty or how to manage it. So and she also has keen interest in management of chronic pain in palliative care, and she's currently working in a Site Cancer Hospital in Bangalore as an associate consultant. Over to you, Dr. Parul, to take us through the session.
Good afternoon, everyone. Good afternoon, Radha ma'am. It's really good to see you. Let me share my screen. Yeah, is my screen visible to everyone?
No, ma'am, not yet.
Not yet, dear.
Okay. Give me 2 minutes.
Yes, we can. We can see now, Parul.
Okay. Is it visible?
Yes.
Okay. So good afternoon, everyone. This will be the third class for you all, and today the topic is pain management, particularly the step 1 of WHO analgesic ladder and adjuvants. You all have learned the basic pain definition and how do you assess the pain in the previous sessions. So I'll be talking about the analgesic ladder, the step 1 drugs and the adjuvants, what all are there in the WHO ladder. So, what is pain? Pain is that says whatever the patient says. And the foremost thing we have to remember that we have to believe the patient, whatever they are telling. Coming to the WHO analgesic ladder, it was in 1986 that World Health Organization proposed the analgesic ladder for the cancer patients, which after 10 years was adapted for both non-cancer acute as well as chronic pain. WHO analgesic ladder is a simple palliative approach in reducing pain-related morbidity in approximately 70 to 80% of the patients. So it is very simple yet effective means of managing patient pain. The original WHO analgesic ladder has got 3 steps. First, step 1, it shows mild pain. As you already know, we can classify the pain depending upon the severity into mild pain, mild to moderate pain, and moderate to severe pain. So for the mild pain, it is a step 1 in which we are using non-opioids with and without adjuvant analgesics. For mild to moderate pain, we come to step 2, opioids for mild to moderate pain plus non-opioids as well, with or without adjuvant analgesics. For moderate to severe pain, it is step 3, in which we are using strong opioids along with the non-opioids with or without adjuvant analgesic. So the important point to remember here is we don't have to mix a strong opioid with a weaker opioid. It is either a weaker opioid with a non-opioid or a strong opioid with a non-opioid. So why it is called as a ladder? Because it is in the form of steps, as you can see. So in the original WHO analgesic ladder, there were only 3 steps and they say we have to go step by step. If the pain persists, we'll go move step up, and if the pain is still persisting, we'll go to the last step. And in case we are seeing any signs of toxicity or side effect, or the person is relieved of the pain, we will again go back down. So the basic principles of WHO analgesic ladder is it has to be by the clock and it should not be on demand. As most of the times we think that whenever the patient has pain, we will give the medicine then. It should not be on the SOS basis. It has to be by the mouth, especially orally, whenever it is possible and feasible. It has to be by the ladder, depending upon the severity of the pain. And the last 4 steps were later on added. It has to be by the individual, according to the individual, how old is the patient, young is the patient, with the related morbidity of the patient, and specifically relating to the attention to the details of the patient, as in how severe the patient pain is with the regular follow-up. Does the patient has any breakthrough pain or not? When is the patient has more pain? Is it in the morning or in the evening? So these are the 5 principles we should always remember whenever we are managing any pain in the patient. So coming to the original WHO ladder, it was unidirectional. And as we can see, there were no non-pharmacological treatments. So the updated ladder, which was started after 10 years of the original ladder, it focused on the quality of the life. So they added the 4th step. And the 4th step means it included the interventions, which includes the palliative radiation and minor procedures, any kind of epidural procedure, regional procedures, which can be used along with the strong opioids. And it can be bidirectional, which means that
Yeah.
okay. Okay. So by bidirectional, it means that when any patient comes with a severe pain, you're not going to say, let me start with the step 1, and then I will think about step 2 or the step 3. Whenever the patient comes with any kind of severe pain, you can straightly jump into the 3rd or 4th step. And depending upon after regular follow-up, you can reduce the pain. The same ways go for the any other kind of pain. It can be acute, you can go with the 3rd step, and for the chronic, you can go from the step 1 or step 2. And in all the scenarios, whether it is acute and chronic, you have to always keep in the mind for the de-escalation with the regular follow-ups. So it was a transition from the step 3-step WHO ladder to this 4-step WHO ladder. And importantly, this 4th step is specifically mentioned for chronic non-cancer pain. So in the chronic non-cancer pain, there's the 4th step, as you saw in the last, where the cancer pain, chronic cancer pain, the 4th step was added at the last. In the chronic non-cancer pain, the minimal invasive intervention comes in the 3rd step, as it is seen that a strong opioid in chronic non-cancer pain can lead to major addictions issues. So what they say, you go if the patient pain is still not able to manage by going to the step 2, we can try for some non-invasive or minimally invasive procedures, and if still despite all the medications or integrative therapies, patient pain is not controlled, we can go with the stronger opioids. This is a brief. I'm not going again back to the assessment of the pain, as it is already dealt in the previous class. The first and the foremost basic things that you should remember in any assessment of pain is building a relationship. You should have an open communication, empathetic ears. We should listen actively. We should convey and show whether either it is verbal and non-verbal way that you care and you really believe that the patient is in pain, because majority of the times what happens in chronic pain is that you don't see any signs of active distress or tachycardia, but the patient is still complaining of pain, so they believe many of the times they struggle with expressing their pain. So you have to understand and believe the patient, and we have to promise that we are going to do the best to the patient, and we are not going to say okay, we are going to completely relieve you from the pain. We have to make sure that we are communicating them with the clear thing that you are going to do your best and you are going to make sure that you are comfortable, because chronic pain is very different from the acute pain, and you have to be very open and relevant to the patient as well. Coming to the step one analgesics per se, as I've already mentioned, it is used to treat the mild pain. In the step one, we have got paracetamol and non-steroidal anti-inflammatory drugs, and along with the adjuvant drugs. And what drug to choose it depends upon the risk-benefit analysis for the each patient. Coming to the paracetamol. So it is a predominantly centrally acting drug, and it inhibits the enzyme cyclooxygenase in the central nervous system. Since it doesn't have any effect on the peripheral COX enzymes, it has got less side effects. But at the same time, since it doesn't act on the peripheral COX enzyme, it doesn't have any particular anti-inflammatory actions. As you must know, or we can say that COX-1 is inherently present, whereas COX-2, which is present on the peripheral COX, is usually inducible after any trauma or inflammation in the tissues. So paracetamol actually has antipyretic and a minimal of analgesic action through the centrally acting COX enzymes. Coming to the dose recommendation, it has to be started the safe dose of 20 to 15 milligram per kg 6 hourly, which can go up to 3 grams per day. Oral dose has to be make sure that it has to be less than 4 gram, and a single dose has to be less than 1 gram. Normally what we prescribe is 650 mg 6 hourly tablets orally, and we also have a sustained release tablets with 1 gram available. And we can also, if the patient can't take orally, we go with the IV paracetamol infusion, 1 gram 6 hourly. And rectal route should always be preserved when the oral route is not feasible. It is also safe for the pediatric use, again in the dose of 15 mg per kg 6 hourly. And usually the toxicity occurs in the doses of more than 90 mg per kg per day. Coming to the numbers needed to treat for the paracetamol. So what is numbers needed to treat? By definition, it means the number of the patients who actually receive the drug for one to have 50% pain relief over 4 to 6 hours compared to a control. So the basic thing that you have to remember is, since it is statistical formula by which we get the NNT, we have to remember that the lower the NNT, the more efficacious is the analgesic drug. For example, if I say that NNT of one drug, X drug is 1, what it means is that I have given a drug to a study group, one drug, and I have given the control from a control side a placebo. So the side where I've given the drug, the first patient only showed the response and had a 50% pain relief. This means after giving the drug to the one patient only, I'm having the response of the drug. It means the drug is very much efficacious. The NNT of paracetamol 650 mg is 5. It means after fifth patient, the sixth patient showed the 50% pain relief response. So since, as you can see, the more you go away from the one digit, the efficacy will slightly goes down. So the efficacy of paracetamol or NNT is compared to be, efficacy is slightly lower than the drugs like ibuprofen and diclofenac. Coming to the advantages and the drawbacks of the paracetamol, the advantages being it has a good safety profile since it doesn't act on the peripheral COX enzymes. So any undesirable side effects are less. There is no adverse effect on the gastric mucosa, so it is well tolerated by the patients with the peptic ulcer disease. It doesn't have any renal effects. It doesn't have any effect on the platelet functions, and it is mostly tolerated by patients who are hypersensitive to aspirin drug. So the disadvantages which you can say is that it has to be given every 6 hourly, so it has quite an increased frequency. It doesn't have any anti-inflammatory action. There are high chances for hepatotoxicity. And what are these conditions? When we are giving the doses of more than 4 grams a day, when there are already impaired liver functions, when the patient is alcoholic and consumes alcohol more than 3 times a day, and if the patient is very much lean, and we have to make sure we are restricting the total dose to the 2 gram. And also in the liver disease, we can give paracetamol, but we have to make sure it has to be restricted up to 2 to 3 grams per day. Overall, paracetamol is safe, but you need to be slightly cautious whenever you are seeing these kind of risk factors. Paracetamol, as you can see, is the mainstay of drug for the analgesic ladder because it is very safe and it has opioid sparing effect. It can be used in a patient with kidney diseases or GI impairment issues. And it has been found that when you are adding paracetamol to any drug, other drug as a combination, the NNT improves from 5 to 2. So it can be used at any step of the WHO ladder. Coming to the non-steroidal anti-inflammatory drugs. So these are the heterogeneous group of drugs which produces their analgesic effect through inhibition of one or both of the isoenzymes of cyclooxygenase, which is COX-1 or COX-2. So it can be either non-selective or selective COX inhibitors. Non-selective interferes with both COX-1 and COX-2, whereas selective COX inhibitor acts only on the COX-2 enzymes. This is the basic physiology. What happens is regarding the prostaglandin synthesis. So the membrane phospholipids are present in the blood vessels, and with the help of phospholipase A2, it is converted into arachidonic acid. And through lipooxygenase enzyme, it is converted into leukotrienes, and with the help of cyclooxygenase enzyme, it converts into cyclic endoperoxidases, where the platelet, vascular, endothelium, and other mechanisms releases the prostaglandins, prostacyclins, and thromboxane A2. So you have to remember that NSAIDs act at the cyclooxygenase level. And as you will see later in the adjuvants, there is the steroids, which is also inhibiting the phospholipase A2. So steroids also will be having an anti-inflammatory action because it is acting on the prostaglandin synthesis. The non-selective NSAIDs examples include ibuprofen, naproxen. Ibuprofen is given perorally in a dose of 400 mg 6 hourly or 8 hourly with a maximum dose of 1 to 2 gram per day. It has an NNT of 2, whereas naproxen is given in a dose of 250 to 500 mg BD, which can be given either perorally or as in form of suppository. It has an NNT of 2.7. So these drugs are, as you can see, NSAIDs have better NNT as comparison to the paracetamol. So these are the selective COX-2 inhibitors, which includes etarocoxib like celecoxib. Etarocoxib comes with the doses of 60, 90, or 120, and it has to be given once a day dose. Whereas celecoxib, but it is now not used because of the cardiovascular side effect profile. Coming to the diclofenac, which we mostly use, it can be given in the form of peroral or IV. It is given perorally in the doses of 50 mg 8 hourly with a maximum dose of 150 mg, and NNT of diclofenac is also 2. And what are the alternate routes of NSAIDs? It can be also be used in the form of topical as well as transdermal. In the transdermal, we have got diclofenac patches in the dosage of 200 mg, whereas in topical, as you know, that topical produces the analgesic effect with a less risk of systemic absorption and toxicity. Topical NSAID comes in the form of gels, creams, and sprays. We have got various like ibuprofen, diclofenac, piroxicam, and ketoprofen in the topical NSAIDs. So, what are the problems with NSAID is that it has, since it is acting on the peripheral COX enzymes, wherever there is a release of prostaglandins, they will have the side effect profile. So it is the GI lining, and especially in the kidney and over the heart, over the platelets. In all these places, they will have their side effects. So how do you select an NSAID? It's a simple table where we are seeing major cardiovascular risk profile or GI risk profile. So if there is no cardiovascular disease with the no or very low NSAID GI risk factors, we can go for a non-selective NSAID, because non-selective acts both on the GI level as well as on the kidney level as well. Whereas selective, they have a better GI risk profile, but the problem with the selective NSAID is that they have much more the cardiovascular risk profile. So if the patient has no cardiovascular disease with GI risk disease, will go for COX-2 with or without PPI, or non-selective. But if you're using a non-selective, you have to add an antacid along with that. If the patient has cardiovascular disease with no or low GI risk profile, we have to make sure that we are giving some alternate analgesia, for example, like paracetamol or tramadol. If the patient has cardiovascular disease with GI risk, we have to go for a alternative analgesia, then followed by a non-selective NSAID. Why? Because the selective NSAID will have a major effect on the cardiovascular system. So the GI risk factors are age, when it is more than 65 years, if there is a previous history of peptic ulcer disease, if the patient is presently on drugs like aspirin, warfarin, or SSRIs. So this is the brief table about the dosages of the various non-steroidal anti-inflammatory drugs. As we have already mentioned, ibuprofen is given in 200 to 400 mg TDS. Diclofenac is usually 50 mg TDS, which can be used as per oral, sometimes subcutaneous, or even per rectal. Celecoxib is not used. Naproxen has given in a dose of 250 to 500. And ketorolac is given in the dose of 10 to 30 mg subcute. Every 4 to 6 hourly, we can go maximum to 90 mg. With the maximum duration, you have to remember it has to be 2 days, not more than that. This is the brief table. I'm not going much in detail. I just wanted to show that if you see the paracetamol and the upper GI erosions and the coronary events, it is nil. If you go with the naproxen with the 1 gram, it has maximum upper GI erosion risk factor with no coronary events. So it is very cardiac safe drug, naproxen. If we go with the ketorolac, it has again upper GI effects with query and plus minus of the coronary events. Diclofenac 150 mg has both upper GI with coronary events. And if you go with the idarucoxib, it has minimal GI side effect profile with much of the coronary event. So whenever we are selecting and giving any non-steroidal drugs, we have to keep these side effect safety profile while giving these to any patients. I will move to the adjuvants. If anybody has any question, we can wait for 2 minutes. I can go through the chats. Does anybody has any questions till now, or we can take the questions at the last? Okay, so
either way should be okay, Parul.
Okay.
If anyone has, let them raise their hands or type in the chat. Otherwise, we'll keep it for after the.
Okay. Sorry. Just for one information, is there any case presentation after the class? No.
Yes, there is a case. They've just sent in one today.
Okay.
So there is one.
Okay. So coming to the adjuvants, these are the drugs with beneficial analgesic effect despite not having being developed as analgesics. So they are also called as co-analgesics. Why? Because they were developed as a classification of some other treatment management, but they then found that they have additional analgesic effect. That is why they were used along with the all the steps of the analgesic ladders. We started using as an adjuvants also. So what the advantage of adjuvants is that they facilitate better pain control with reduction in analgesic consumption as well as the concomitant side effects. So whenever you are using any one non-steroidal anti-inflammatory drugs and if you feel the side effect profile is much more, you can combine them with the adjuvants and see whenever possible. So it will have a better effects. So we have a various list of adjuvants, which includes antidepressants, anticonvulsants, topical anesthetics, topical therapies like capsaicin. We have got corticosteroids, bisphosphonates, cannabinoids, and many, many more kind of drugs. I will go briefly about these drugs, not going much in the details. So one thing we have to remember that even though we are calling them as an adjuvants, these certain drugs among the adjuvants are considered now as the first-line treatment for many specific pain conditions. For example, the European Federation of Neurological Societies has recommended duloxetine, SNRI or anticonvulsants or tricyclic antidepressants for the painful diabetic neuropathy treatment as a first-line drug. So even though they are called as adjuvants, in many of the specific pain conditions, you have to remember they act as a first-line treatment. Coming to the antidepressants, though the mechanism for management in the neuropathic pain is very unclear, but one thing we have to remember clearly is that the analgesia effect of any antidepressant is achieved at the lower dosage and faster than the onset of any antidepressant effect, which usually takes up to 6 weeks. The pain relieving properties of antidepressants are independent of any effect on the mood of the patient. So usually we have got two main group of antidepressants, like the older tricyclic antidepressants and now the newer drugs like selective serotonin reuptake inhibitors and serotonin norepinephrine reuptake inhibitors. So tricyclic antidepressants are recommended, as I already mentioned, as a first-line drug for the treatment of the neuropathic pain. The dosage is 75 mg per day or less over the age if you're using more than 65 years of age, because it has side effect profile, the risk of anticholinergic as well as the sedative side effects. So whenever you are using any tricyclic antidepressants in the elderly patient, you have to make sure either you are avoiding this or using at a very minimal dosage. Because it has been found that if you increase that dose up till 100 mg, there has been found the incidences of sudden cardiac death. Depending upon the chemical structure, they are divided into tertiary and secondary amines. The secondary amines are examples of desperamine and nortriptyline. They are as effective as tertiary agents like amitriptyline, which is commonly used. Advantage of secondary amine is that they have less side effects as comparison to the tertiary agents. Adverse events are because the high side effect profile, many times the patient, they stop the treatment in between. So it is very important that whenever you are giving any kind of a drug, including the analgesics like tricyclic, you have to convey them that there will be some side effects and you might not see the response as fast as you are expecting, but the side effect profile will slowly wear off so that the patients will not withdraw from the treatment. These tricyclic antidepressants are contraindicated in patients with recent MI, arrhythmias, mania, and those who are taking MAO inhibitors. And it has to be very cautiously used in the glaucoma patients. So if you see the amitriptyline, which we use usually, they comes in tablets or syrup form. In tablets, we have got 10 mg, 25 and 50 mg. Syrup comes in the concentration of 25 mg and 50 mg. So whenever you are starting amitriptyline, we have to start with the smaller dose. You can start with 10 mg, slowly increase to 25. And depending upon the patient tolerance, you have to titrate the drug. And at the same, as I already mentioned, we have to convey this, that patient will have a response in at least 4 weeks. These are the side effects. Side effects like dry mouth, constipation, blurring of vision, urinary retention, dizziness, tachycardia, delirium. There will be orthostatic hypotension, episodes of syncope, there can be QT prolongation, and other side effects like sedation, sexual dysfunction, weight gain. And this is briefly about the NNT of drugs which are used for the neuropathic pain. Tricyclic antidepressants has an NNT of 3.6. As comparison to the other drugs, they have a very good NNT, but because of the side effect profile, sometimes we have to combine them with other drugs like pregabalin and gabapentin so that they get well tolerated. Coming to the SSRIs and SNRIs, usually if we use the SNRIs like duloxetine and venlafaxine, which have found the advantages for the analgesic effect. Since they have got lesser side effect, they are sometimes considered first line before using the tricyclic antidepressants. The adverse events associated with SNRIs are usually nausea, dizziness, drowsiness, constipation, and dry mouth. Again, duloxetine has to be contraindicated whenever the patient has glaucoma. And SSRIs are found to be less efficacious and usually not used in any kind of neuropathic pain. So for neuropathic pain, the first line, as you can see, are the adjuvants. Adjuvants, as you can see, these are tricyclic, SNRIs, pregabalin, and gabapentin. And second line drugs are lidocaine patches, capsaicin high concentration patches, which is only for the peripheral neuropathic pain. And in third line, it is the stronger opioids. So it is not always that what you see as step 1, step 2, step 3. In specific conditions, the first line drugs changes. Coming to the anticonvulsant drugs, they act through a variety of mechanisms by decreasing the synaptic transmission and elevating the threshold for the repetitive firing of the nociceptive neurons and reduces the discharge. Examples are like gabapentin and pregabalin. The majority of the times act via the voltage-gated calcium channels in the dorsal horn, thus resulting in the release of excitatory neurons like neurotransmitters such as glutamate and substance P. Pregabalin is an analog of gabapentin, has the same mechanism of action like gabapentin with a higher affinity for the presynaptic calcium channels. Side effect profile they have, which includes dizziness, drowsiness, peripheral edema, and dry mouth. And gabapentin is usually given in a dose of TDS, and it has to be again titrated very slowly according to the individual tolerance because of the side effects. Pregabalin is administered BD, and both of these drugs doses has to be adjusted in patients with renal impairment. Gabapentin comes in capsule form, tablets form. So usually we start with 300 mg HS and slowly we increase up to BT, then TDS, and we will see after a week or so how is the patient responding, how is the side effect profile, and depending upon that we can increase and go maximum up to 1.8 and sometimes up till 3.2 grams in 24 hours have also been used. But whenever you are using this high dose, you have to make sure that the patient profile, any side effect patient is having or not. Coming to the pregabalin, it comes again in the capsules as well as oral solution. It doesn't come in the tablet form. So capsule, we have got 25, 50, 75, 100, 150, 200 and 300. We start with 50 and 75 mg. We can go with the OD followed by next day BD, and in frail and old patient, we can start with the OD dose or HS dose. So we can slowly by 7 days, 8th day, we can increase, and we can go up till maximum of 300 mg BT doses of pregabalin. After anticonvulsants, we have got topical analgesics. By topical means they act at the site of the application with minimal side effect profile to the systemic system. We have got in topical analgesics lidocaine and capsaicin. If you remember, these drugs are considered as a second-line drug for management of the neuropathic pain. Lidocaine acts locally, and it acts like any other local anesthetic through the inhibition of the voltage-gated sodium channels. And it has got very minimal side effects like skin reactions. We can use up to 3 patches a day for a maximum of 12 hours, and we can use them. And coming to the capsaicin, it is thought to elevate the pain threshold by reducing the amount of substance P available to act as a neurotransmitter. It comes in the form of 0.075% or 0.025% cream. And in specific situation, we have to use a higher dose 8% patch. So whenever you should remember that capsaicin is actually a derivative of a chili pepper. So whenever you're using capsaicin, it has to be applied with gloves and with proper instruction. And you have to tell sometimes initially the pain will increase, but in subsequently there will be a relief. Coming to the corticosteroids. Corticosteroids are again an adjuvants which can be used at each step of WHO analgesic ladder whenever we are considering as an anti-inflammatory effect. We have got a specific role in clinical scenarios like spinal cord compression, any vein metastasis, and bowel obstruction, where improved analgesia is actually a secondary benefit from the primary indication of reduction of the peritoneal edema. This is the equivalent doses of various steroids. We commonly use dexamethasone. It is used either as an oral or subcutaneously in the palliative care settings. The equivalent dose is 2 mg. Hydrocortisone is 60, prednisolone is 15, and methylprednisolone has a 12 mg equivalent doses. Whenever you have to remember, whenever you're giving any steroids, it has to be given in the morning, and we have to make sure that we are giving antacids along with that because of its effect on the GI system. Since it can alter the sleep cycle, dexamethasone is usually given before evening time, usually in the morning and the afternoon time, in the form of tablets whenever patient can take the steroids or tablets orally. Bisphosphonates are also examples of adjuvants. Usually they form the standard therapy for any hypercalcemia or any prevention of skeletal events in some cancers, but they are considered not as the first line, but as a second line treatment for the cancer pain associated with the bone metastasis. For the bone metastasis, the palliative radiation is considered as the first line treatment. So it is used as a second line treatment for the bone metastasis. We have to remember the adverse effects of bisphosphonates, which are renal toxicity, hypocalcemia, and osteonecrosis of the jaw is the major side effect of the bisphosphonates. So it can be reduced by starting with a dental assessment prior to the starting of the treatment and avoiding any invasive dental treatment when the patient is on IV bisphosphonates. And again, the doses needs to be altered in the renal impairment. These are the major 3 bisphosphonates which are usually available. These are disodium pamidronate, zoledronic acid, and ibadronic acid. Baclofen is effective in cases of any muscle spasticity, in trigeminal neuralgia, again in neuropathic pain. Especially, we can also use baclofen as an adjuvant for the hiccup and musculoskeletal spasm or any GI spasm. The dose of baclofen is started with the low dose of 500 mg BD then increase to 3 days, and it has to be increased in 3 days. We can go maximum to 20 mg TDS. So the mechanism of action of baclofen is it binds to the GABA B presynaptic receptors within the brainstem, dorsal horn of the spinal cord, and other CNS sites. It has bioavailability of more than 90% with half-life of 2 to 4 hours. We can use it orally, topically, and in fact, nowadays it can be used as an intrathecal pump, usually in any cerebral palsy patients. Sometimes whenever all the major pharmacological treatments are exhausted for lower limb pain, this intrathecal baclofen is used in those as an intervention procedure. And rest of the other adjuvant drugs, it's a very huge drug list. It also includes like skeletal muscle relaxants, like thiocolchicides, tizanidine, chlorhexazone, neuroleptics, like olanzapine, which is specially used for delirium, agitation, nausea, vomiting, antibiotics whenever there is a painful lesion because of infection, sedatives because sedatives, anxiolytics, if the pain patient is sleeping well, the pain automatically comes down. And especially laxatives, even when the patient has a very severe constipation and the patient is in pain, so laxative will help. So whenever the patient has neuropathic pain, we can use antidepressants and anticonvulsants. If the pain is due to the colic, we can use antispasmodic. If it is due to the bone metastasis, bisphosphonates. If the pain is due to the infection, we use antibiotics. If it is due to edema in any part like brain or GI system or nerve compression, steroids act as an anti-inflammatory in those conditions and act as an analgesic for that. Muscle relaxants, if there is a muscle spasm or cramp, and also remember just NMDA receptor blocker like ketamine can also be used for the neuropathic pain as an infusion. So this is to get the answers from you. Anybody can write down the chart and can speak. If there is a headache due to cerebral edema, what is the possible co-analgesic that can be used? You can write in the chart. Yeah, corticosteroids. If there is a painful wound, antibiotics, yes. If there is intestinal colic,
Antispasmodic.
yes. It's very simple, I know. It's very easy for you. It is just to... so if there is gastric mucosal pain, what will give?
Sucralfate, pantoprazole.
Yeah, pantop, antacids. Gastric distension or skeletal muscle spasm?
Prokinetic like domperidone
Yes. Cardiac pain?
Nitroglycerin.
Nitroglycerin.
Yes. Yeah. I know it's very easy. Yeah. So yeah, all of you were absolutely right. Okay. And I think we have got last slide. Again, very simple thing. You have to choose adjuvant or adjuvants. Sorry. Yeah. A, B, C, D, E, F, G.
All of them can act as adjuvants in specific
All
symptoms.
of
All of them are.
Exactly.
All of them are adjuvants.
Yes. All of them are adjuvants. And let us go with the summary. As we begin with the WHO step 1 drugs, it is usually sufficient for mild to moderate pain. We can start with the single drug or combination. And one thing we have to remember that it has to be round clock. We have to make sure that we are giving something so that night duration is covered. So we can give a sustained release tablets at the night as diclofenac sustained release tablets or a paracetamol sustained release tablets. Whenever you are finding any component of neuropathic pain, you have to remember the paracetamol or non-steroidal anti-inflammatory drugs are not going to help. So you have to add and anticonvulsant or antidepressant drugs, and adjuvant drugs like sedative has to be added if you're finding patient has some anxiety associated with it, because if the patient is sleeping well, automatically the pain threshold is increased. So patient will perceive less pain. And importantly, psychosocial support, because pain is not any pain has, as you know, we have to treat the patient as a whole. We have to treat the total pain of the patient. So don't ever forget, whenever you are dealing with any kind of pain, it is only the pharmacological aspect. We have to make sure that we are a little bit trying to cover the non-pharmacological aspect, especially the psychosocial. A little bit about, again, summary about the WHO analytic ladder. Even though it has been there from 1986 and it was actually designed by non-pain physicians, because it's very simple, and it is still, despite few concerns or risk regarding the WHO ladder, it is still considered as a universal palliative method of treating pain. But still, sometimes we feel that we are not managing the patient pain well, and there still the pain physicians are getting referrals. Why it is that? Because we have got less knowledge regarding the drugs, regarding the pharmacology, sometimes because of our own fear, because we fear that the patient will have addiction. We start giving the underdosing, we start doing the underdoses of the drugs. We don't think about the timings. We don't ask about the breakthrough pain. We don't uh, manage the pain of the patient according to his daily routine. Sometimes what happens is that we don't give the drug before any physiotherapy or any movement of the patient. So patient will have extreme pain during that procedure. So during that time, we have to make sure that you are giving the drug half an hour to 1 hour prior to the procedure. We have to make sure that we're covering the nighttime aspect. And sometimes we only even we see the WHO ladder, it is only seeing the one dimension. We are seeing only the physical aspect. But as you have already learned in the last class about the assessment of pain, it doesn't have to be treated as a one dimension. Sometimes, as we already know, we can see, if you see step 1, step 2, step 3, we don't see any neuropathic management of the pain. So neuropathic management of pain is managed separately. As you saw, the first line, it is pregabalin or anticonvulsants. And sometimes whenever we are using a WHO ladder, we see NSAIDs in the step 1 for the mild pain. So we don't sometimes think it can have a side effect profile also. So believe it is safe. So we start giving to each and everyone without thinking about any side effect profile. So sometimes it gets misused. Thank you.
Thank you very much, Dr. Parul. We had an extensive insight on all the information required. There were few queries in the chat.
Yes.
One was dose titration for renal, and then about osmotic for cerebral edema, I think.
Okay.
Sangeet, can we come out of this presentation screen and we can go to. Sangeet is there?
Good evening, ma'am. Can I ask one query, please?
Yes. See, you can go ahead with your query, and also, like if anybody else, no, yes, you go ahead with your query, and then afterwards we'll go back to those queries on the chat also.
Okay, thank you, ma'am. I wanted to ask, when the patient comes, the assessment process is complete. The patient during the consultation is still in the process of pain. So, does pain alter the ability of a person to decide or to take or to give consent? And second thing, is it like in sometimes oncology, what happens in initial part of the diagnosis? sometimes we break the diagnosis to the patients a bit late. We inform the diagnosis earlier to the attendants. So when it comes to consultations involving pain and the treatment options, so to who is our primary liaison in with respect to communication?
I think that topic will be covered in communication part. So,
Okay,
and also the initial bit, what you said, I didn't catch. Can you? Is it is somebody else's? I think somebody else is cross-talk.
Yeah.
Doctor, can
Yeah,
can you just
I got
you
the
go with Parul?
I got the mm, can you please mute?
ma'am, I wanted to ask like when someone is in severe pain.
Yeah, I got your question. Yeah, definitely. When someone is severe pain, their understanding or consent giving capability is quite hampered. So in those situations, we have to ask them who is the primary caregiver. If we're asking in particularly regarding some consent for some procedure or some information, you have to make sure that patient is addressing someone as their primary caregiver, and you can share or you can tell them regarding the procedure or something, whatever you want to share to the patient, or you can whatever the procedure you want to do with the patient. So it has to be the primary caregiver and it has to be documented.
Okay, thank you so much, ma'am.
Yeah.
It's in the chat box. We'll go through that, Parul.
Yeah. Any other anesthetic agent as adjuvant? Yeah, there is ketamine also. There is, in fact, lignocaine infusion also, which can be used as an adjuvant. So yeah, these two are anesthetic agents which are used as an adjuvants. Dr. Anju, uh, if you want to ask.
And there was something about before that. There's one drug of choice for neuropathic pain due to that anti-TB. That
Okay,
what
drug of
are
choice
they
for
trying to ask?
neuropathic pain due to drug linezolid. We usually add paradoxin with the any MDR TB drugs. If there is a neuropathic pain due to linezolid, uh, yes, we can
Is
use
it adverse reaction due to linezolid? Is that what she's trying
it
to
is, I
say?
think, secondary reaction because of linezolid. Then it can
Okay.
lead to neuropathic pain. Again, you have to remember when it is neuropathic pain, you have to go with the first line drug, whatever it is mentioned in the for the neuropathic pain. It's irrespective of the etiology of the neuropathic pain.
And there was something else about role of osmotic diuretic in brain.
In brain metastasis. So osmotic diuretics are usually not used because usually the problem during the brain metastasis is the perilesional edema, and osmotic diuretics helps in reducing the overall ICP. So that can be used as a management in the brain metastasis. But if you ask for an adjuvant as an analgesics, it will be as corticosteroids, which will actually help in reducing the perilesional edema. So in that case, it will be the corticosteroids which is used.
Methalpred will be used in
palliative side. There is one more query
yes.
by Dr. Richa. When to give gabapentin and when to give gabapentin not for neuropathic pain? Usually, gabapentin is given along with the TCS or what you can say as an amitriptyline as in combination. So you can start with the gabapentin and amitriptyline as in combination if the patient is coming in severe pain to you. As I've already mentioned, if the patient is not tolerant to gabapentin per se, and if the patient has a kidney renal impairment, in those situations, we'll try to avoid the gabapentin.
No.
Ma'am, can I say something?
Yeah, please.
Ma'am, I was asking about when to give gabapentin along with amitriptyline and when to give gabapentin plus nortriptyline combination.
So if you are seeing that patient is coming if the patient is coming with a 1 month or 2 month history with the kind of pain which you can see is mild to moderate or moderate to severe, you can start with a single drug, either amitriptyline or gabapentin. But if the patient is coming with a long-standing chronic pain, which is approximately 6 months, 7 months, and patient is not getting any relief, and if you see that patient is actually in a severe pain with another stent, then you start with the combination as a straight measure. You don't wait with the single drug and then start adding any analgesic. So it depends upon patient to patient and patient profile as well.
Ma'am, usually in practice, I have seen that
Yeah.
when the patient has no relief, then from gabapentin we shift to pre-GABA. So
yeah, but the difference is that gabapentin is cheap and pregabalin is costly, but they have more or less the same usage profile. It is usually we do the combination of amitriptyline and gabapentin or nortriptyline and pregabalin, and then titrate the doses rather than shifting the patient from one drug to another. We usually what we do is we increase the doses of the drug before moving to any other class of the drug or any other type of drug.
So there is no different indication for both of the drugs?
No. It is usually
one thing with amitriptyline, sorry Parul, with amitriptyline and nortriptyline is patient compliance is said to be better with nortriptyline than amitriptyline. But the important thing, when the other doctor was asking, this time factor for that answer, as Dr. Parul mentioned in the presentation, you have to explain to the patient amitriptyline and paracetamol brufen are not the same. The pain relief what you will get with paracetamol or brufen is immediate, whereas with these type of adjuvants the relief will take 2 to 4 weeks. So you have to initially religiously take the drug. You may not see or find any benefit. That has to be conveyed. So many times the problem lies there. So they consider every tablet. See, how will a patient know mechanism of action and when peak effect? So what did Dr. Parul mention in the topic? She said 2 to 4 weeks. As a pain physician, it is our duty to say first 2 weeks you may not see much benefit. End of 5 days or 7 days only, you will start to see the benefit. So if you tell this to the patient, they will find it better off. So that is one important thing. And these combination things, ideally start with single ones, age, everything. And another important thing, as mentioned by Dr. Parul, the duration. If someone is struggling for 6 months, 1 year, something like that, and that stage doing something very slowly, that is where they say, oh, I'm not getting any, they keep on moving doctor to doctor. So you have to assess the patient properly and then start, and ideally one drug, then combination. That is how. See, a little bit of patience is also needed when you treat chronic pain patients. That is an important. All of us will get, and as you start doing, you will know the importance of it. And renal drug doses, they've asked
Ma'am, I had tried to answer in the chat. I thought because of the time constraint.
Yes. If you've done that, because
question I didn't get it from the Dr. Abdul Hassan is
old age.
I didn't get. Is there any easily accessible source wherein we can refer for a max tolerated doses? What do you?
That's all.
Is it
I think he's
for a reference?
See, that is, you have books, you have books which have renal corrected doses. There are, like, you have these MIMS and SIMS. There are books which will have, usually in intensive care and those type of places, I have seen books which will have renal doses. So basically, one ground rule I will say, first is you reduce the frequency and reduce the dose. 50% reduction in dose and 50% reduction in frequency. For example, TDS can be made BD. If the dose is 50, make it 25. These are the standard norms when you see, and you follow up with the renal parameters. Did that make any sense to Dr.
Thank you, ma'am.
Dr.
Thank you.
Abdul
That's very
Hassan?
helpful. Thank you, ma'am. That's very helpful.
See, and there are books also about it. If you find out, because I have seen those things. So these are the standard things in that book also to be mentioned, and this is how we follow.
Okay. Are there any
Okay.
adjuvants that are absolutely contraindicated in these subgroup of patients like renal failure and liver failure? Are there any subgroup of adjuvants that are contraindicated in these patients?
Yeah, if we see the elderly patients, we try to avoid amitriptyline because of the anticholinergic profile and cardiac profile. So we have to be very cautious in elderly patients whenever you are trying to use any adjuvants. So yeah, elderly patient is the age group, and renal and cardiac, major cardiac, any patient had any major cardiac history. In those cases, you need to be very careful.
Okay.
That's what in
also,
those patients,
with the use
avoid
of
tricyclics. No, that's what in those cardiac and elderly, avoid tricyclics and use gabapentin 100 milligram dose. Okay. Just 100 milligram tablets are available internationally. Okay. 100 milligram tablets you start. In 100, 200, they will get so many post-herpetic neuralgias. I have used 100, 200. With that itself, they will get very good benefit. Maximum 300 if they are 67, 70-year-old. If they are 70 plus and all, just with 100 or 200, 100 OD for few days and then make it to 200. They will get very good benefit in 3 to 6 months. I've used tapered and stopped also.
Especially if there is herpetic neuralgia. If there is herpetic neuralgia, you can use the lignocaine patch, which doesn't have any systemic side effects.
Thank you, sir.
And one more thing I just wanted to add on, timing. Like when you give these patients, when you put these patients on these drugs, you specifically and very clearly tell them when to take it, not to take it at 11 in the night or 10 in the night. The next day morning, they will have lightheadedness because of the duration of action of the drug. Don't blame it as side effects. So whenever you prescribe these type of medications, you telling them when to take it. And explaining, if you miss it, don't take it that day. Then you take it, and then one day having a bad side effect is enough to blame that the drug is not working, and then they will stop it. So in all these drugs, it is our duty lies a bit more. You have to explain these things. Many times they say, oh, nobody tells us all these things. See, if you practice, you have to explain also. So those will help in a long, long way for the patient and for you. Okay. Anything else? If there's no more queries, or if anybody wants to ask anything, go ahead. Or we'll go with the case presentation and then come back. Can we go ahead with? Can we go ahead with the case? Go ahead.
If the patient is renally impaired and he or she is in pain, which drug can be used? So we have to go according to WHO analgesic letter. If we know that patient is renally impaired and patient is in pain, and if we feel that pain is severe, we have to straight go either to the step 2, which is the weaker opioids, or if you see the patient is in severe pain, we'll directly jump to the step 3 opioids. You don't have to be in the step 1 and think about which drugs to use.
Yeah, excuse me, can I ask something? I put rather
yes.
in the chat box. Is it advisable to give a ketamine drip at home when you make a home
yes,
visit?
yes, someone had asked that.
Yeah, I had replied in the chat box. No, you cannot give in that home.
Cannot.
It has to be hospitalized either as a daycare or admitted, because it has to be given in the day of 3 days. So you need to be admitted, patient has to be under monitoring, and you have to make sure that patient's psychomimetic effects because of the ketamine are reduced by giving any benzodiazepines before the procedures or haloperidol before the procedure. It should not be given at home.
No, not at all. That query or doubt itself should not be there. it is not a safe drug to be given at home. Clear?
Low
Yes.
dose ketamine can be used. We use it in labor analgesia sometimes. So can it be used as a low dose ketamine
Yes, ma'am.
drip?
It has to be used
At home. They
not
are
at
all
home.
asking at home.
No, not at home. I think since you
Am I
mentioned
audible?
labor anesthesia, in the hospital we use a low dose ketamine infusion for neuropathic pain. It has shown some good results, especially in the neuropathic pain.
See, Dr. Pushpa, what I was trying to say is only for home. We use a lot of ketamine for pain relief in hospital. That is under monitored care. It can be given. As you said, labor and yes, is that given at home, Dr. Pushpa? Can't hear her.
No, not at home, but for labor analgesia,
Yeah.
we
No,
had
that's
used
what.
it in
Yes,
No,
hospital
yes.
only, but very low dose, which is
Yes.
almost
Exactly. Dr. Parul did mention about ketamine in one of the options for pain relief. Yes, it is very, very much used in hospital. Okay, only thing for
Especially
home,
the
the other
neuropathic.
doctor had asked for home.
But we have to remember one thing: ketamine's evidence is only has come for the neuropathic pain, and not as a good evidence for any other type of pain. That is only the one thing which needs to be remembered. Ketamine studies are for neuropathic pain conditions like fibromyalgia, not for any other pain indication per se. Thank you.
Okay, then we'll go ahead with the case presentation.
Dr. Sri Sudha is going to present our case presentation today. Ma'am, over to you, ma'am.
Good morning, good evening, ma'am. Myself, Dr. Sri Sudha, assistant professor in Yoga. Today, I thought to please
Ma'am,
move
your
on next
audio is
slide.
little bit feeble. Can you just be louder?
My voice is not audible.
Yeah, now it's clear.
Okay. Okay. Myself, Dr. Sri Sudha, ma'am. Good evening, everyone. Please move on to next slide. This is a case about 45 years old female came diagnosed as a sciatica pain. Just next slide. Complaints like pain in the hip region, and she's having pain as a dull and achy with occasional sharp shooting pain radiating down her left and sometimes right leg as well. So she reports difficulty in performing her routine activities and disturbed sleep due to pain and unable to lie on the bed as well. Coming to the history of present illness, she is having a history of type 2 diabetes mellitus and osteoarthritis, GERD. She is currently managing her type 2 diabetes with oral drugs and GERD medication PPIs with medication, but prefers to opiates for pain management. Her preferably is she's having some misconceptions that opiate is having addiction like that. So on examination, it is a case diagnosed as sciatica because tenderness in the lumbar spine area and limited range of motion. So no neurological deficits are observed. So this is a case of sciatica. Next slide. So coming to the treatment and significant investigations, treatment is mainly patient is referred to physical therapy for core strengthening and flexibility exercises. And as we already discussed, so far Madam has discussed, NSAIDs will be cautiously prescribed considering her history of GERD. So we should be focused mainly which is having less GI side effects. A regular regimen of this acetaminophen will be prescribed with monitoring of LFT, as the patient is non-diabetic patient. So we should be monitoring at least monthly or twice a month. Topical analgesics are recommended for localized relief and particularly targeting the areas affected by sciatica. Referred for cognitive behavioral therapy, mainly to develop the coping strategies for pain, so that mentally she is not going to affect much difficulty. And discussion of non-pharmacological treatment modalities such as physiotherapy, acupuncture, or meditation. And coming to the investigation, only LFT is advisable to monitor unless until there is any history. Only kidney function tests are suggested. Otherwise, no further investigation is advised. Next. So coming to psychosocial aspects here, main thing is chronic pain significantly affects patient daily life activities and also sleep quality. So she expresses concern about the potential risk of opioid addiction and side effects as well. So the main misconception of these opioids, as well as her mentally, she is getting distracted because of this daily routine activities distracted and sleep quality. Next. Coming to the medication, patient currently takes medication for type 2 diabetes and GERD. NSAIDs and acetaminophen will be added to her regimen for pain management. Next. Main concern is mainly to achieve the effective pain relief without relying on opioids. Next. Coming to the summary, patient, a 45-year-old woman with sciatica pain, presents with functional limitations and disrupted sleep. Given her medical history and preferences to avoid opioids, a comprehensive non-opioid approach, including physical therapy, NSAIDs, topical analgesics, and CBT, and alternative therapies is recommended. So close monitoring of LFT is advisable as she is diabetes, and plan to optimize pain management and enhance patient quality of life. Next. Here I want to discuss mainly the exploring the patient preferences for this pain management and educating the patient about this benefits and any risk of this non-opioid or NSAID treatment, addressing any obstacles to adherence to the treatment plan, and emphasizing the importance of regular follow-up and communication to monitor progress and adjust treatment as needed for optimal sciatica pain management. And also other point is whether in this case any palliative therapy is advisable or not. That also actually I'm not clear about that point. That point has to be discussed in this case. And next slide, please. So this is all about. So far, just now, Madam has discussed all about extensively about the NSAIDs. So this is a case of mainly sciatica. As Madam said, this is GERD case. So to reduce this GI side effects, we have to start with the low dose of this COX inhibitors, mainly paracetamol or ibuprofen. Because of no swelling, nothing is there. So mainly simple analgesic with low dose we have to start. Then if the patient is correct and comfortable, then simultaneously we have to increase the dose gradually. I think, and moreover, coming to this main focus of point, I am also not clear whether palliative therapy or something here it is applicable or not, ma'am, because even I am having that doubt, because it is a simple normal routine cases. Here that much mentally whether the patient is getting affected, so we need to counsel that and all. I am also not clear. You have to tell and discuss.
Hello.
Hello. Ma'am.
Thank you very much, Doctor. Parul, you can go ahead.
Yeah, first I will go with the question which query you had, Doctor.
Yeah.
Yes, definitely it will come into the palliative care. Palliative care, any patient having any kind of distress
Okay.
will be under palliative care. They will need palliative care. Palliative care doesn't mean any end of life care treatment. It means any
Oh, yes.
patient. So
Yes, yes.
we have to decide. We have to decide how we are going to help the patient in relieving the distress. So yes, it
Okay.
will come. It will come definitely because it is a chronic pain
So
and
here,
stress.
main thing is distress. The patient should not get distressed. That is the main motto of this palliative.
Yes, that is the first palliative thing which we have to make sure. Along with the pain management, we have to look for the distress factors which the patient has. I have few questions for you here. Why the patient is afraid of using opioids, as in who advised her opioids for
Actually,
sciatica?
not like that. Just I made myself this because I'm a pharmacologist. I
Yeah.
cannot able to see the patients regularly.
Okay.
So this is a simple introduction
Okay.
topic. So I thought to.
Okay.
So this is also opioid misconception.
Okay.
We need to
Yeah.
counsel now. So in that way, I thought.
Okay.
So counseling also it comes into picture. So in that way, I thought that
Oh.
it will be good. Like
Okay. Okay, understood. Because that the thing was going in my mind because sciatica is purely a neuropathic pain. So
yeah, yes, yes.
if you're using opioids, I don't think it's going to help for a long time. Only for the acute
Yes, yes.
component of the pain, we can start with the weaker opioid. So whenever the patient, if the patient has an anxiety regarding opioids like tramadol to use with, if we are thinking in that way, definitely we have to tell
Okay.
the side effects patient is having, which will be mostly constipation. So whenever we are advising any weaker opioid, which will be dealt in the later classes about step 2 and step 3, it was not today. So you will see that whenever we are advising opioids, it has to be used along with the stimulant laxatives. So that is the
Okay.
one side effect or GI upset. So you have to make sure that you're covering both of these things cautiously and advising the patient as well, and ensuring that patient is taking any stimulant laxative along with the weaker opioid.
Oh,
Regarding the distress component, we need to explore more.
oh.
And in your case presentation, how much severe was the pain, and when was the pain more, whether it was, and during what activities patient had more pain? These 2, 3 points, I think I missed.
Yeah, yes, actually, I didn't mention about that.
So whenever,
Severe.
so whatever, even you, it is like basic pain presentation can be any type of pain. We have to remember the basic mnemonic or basic assessment of the pain. PQRSTU, it is very simple. Or EMA karke, evaluate, ask, severity, then type. When is the patient has. These are the basic assessment which needs to be asked whether these are positive or not positive in any patient. And it is just the basic thing. It's all.
Okay.
Exactly, like same as few things I too thought was see opioid. No need to jump into opioid for non-cancer pain, and this case per se is a chronic pain which has to be explained, assessed more in detail, and then you have to look at go like that's you can use a step ladder for this also. Once you have a proper assessment, and then pharmacological, non-pharmacological options, everything has to be addressed, and then based on the severity of pain, you decide what is the drug, and then that opioid is a choice only, and it's not first line.
Yeah, yes, ma'am.
So and then mostly, from what you looks like this, it is not. It is a neuropathic pain. So
Yeah.
neuropathic pain medications have to be, and then you have to add it with analgesic, especially when they're having pain. If you're going to say only neuropathic, you will give. Uh, because as patients, they want relief. I said it will take 1 week. Who will be willing to wait for 1 week without any benefit? So it has to be as we said on like the previous session, multidisciplinary assessment, then total pain management. So that is how it has to go. And this will be like, as we know, palliative care is not only oncology. That's what we said on day one. It is oncology, non-oncology. So this will be part of it, but has to be assessed in bit more detailed and managed appropriately. And also, no, like the other modes of non-pharmacological management, everything will be covered in the next couple of sessions. In pain itself, and then you have some more sessions on psychology itself. You have one full session. So various aspects will be covered, because only when it is done, and maybe with a good intention of bringing up the myths of opioid, you might have thought about it. That also we will talk in detail when we do opioids per se, because in that you need to know. Day one, Dr. MRR said, see, opioid nowadays has got so many uses. So all that also has to be, these myths have to be explained and removed. You can't force anyone to do anything, and that won't work. Okay, so those are the important things. Anything else in the chat? I'll have to check, give a minute. And maybe we can come out of, yes. And nothing else in the chat. Anybody else wants to ask anything? Anybody wants to ask, you can unmute and ask. And I hope all the chat queries we have dealt with. I'll just double check on that.
This is Shanmuga Priya here.
Go ahead.
It's a very personal experience question. Recently, a few months ago, I had a bout of post-viral arthritis diagnosis, and I suffered for almost 8 to 12 weeks with classic arthritis pain. So I was recently diagnosed as diabetic also, so started with glycomet 500 SR. OD, and I have a history of atopic hypersensitivity. So I get asthmatic attack or skin allergies, exposed to any kind of allergens, which I couldn't identify so far. So the thing was, during the treatment period, I had severe pain during the first 4 to 8 weeks. The body stiffness and any kind of movement, all the small joints, everything, but everything was ruled out. So the working diagnosis given was post-viral arthritis after a week of viral fever, few days of viral fever in December. So I was prescribed, because of the history of diabetes as well as my hypersensitivity, allergic history. I was prescribed paracetamol with tramadol, Ultracet, just BD, which was not enough for my pain control at all. So should my physician have to be that cautious because of my diabetes history and allergic history? I was not prescribed anything else. I was given paracetamol 1 gram, sustained release for the first week, no pain control. So I was moved to Ultracet, BD, for the rest of the period till I got test. The pain went away after 8 weeks, like slowly went into the resolving phase. So I suffered through 8 weeks of almost 4 weeks of severe pain, except for the first few hours after I took Ultracet. So should I have been that cautious, or what I could have done? I mean, my physician could have done, or what I could do to a patient in the future?
You go ahead, Parul, then I will.
So sorry to hear that we had to go through. Dr. Sharma Priya. I think pain management was slightly, could have been, what you say, medicines should have been edited according to your pain response, rather than just prescribing OD or BD. So next time, if something like that is happening, any kind of a selective NSAIDs would have been better for you, especially for the joint pain, because it was an inflammatory kind of a pain. what about your sensitivity for non-steroidal drugs? Are you able to tolerate that?
Yes, not I don't think any kind of drugs have actually precipitated my asthma attack or anything, except for a mild GI discomfort with Brufen.
Then,
So,
it should have been an alternative treatment regimen with the PCM tramadol along with the in between an OD dose of heterocoxib. Probably would have helped you, but still it would have it needs in proper assessment and reassessment whenever we are prescribing any drug uh, to anyone. But still, I'm sorry that you had to go through the pain.
okay, so the tramadol paracetamol combination. So as you mentioned, ma'am, for the maximum dosage. So what
Yeah.
I had, I think it was that is the one I will have to remember according to the analgesics by the clock, not by demand. So by the clock, it should have been I think TDS or QID would have been better.
Yes,
Yes.
definitely,
Yeah.
definitely. We can
And
go to
this,
the maximum dose. We can go to the
Okay.
maximum dose. I
Okay.
don't think you had any contraindication to go till the maximum dose just because you're diagnosed with diabetes. We just needed to be cautious. We should be more focused on managing your pain.
Mm-hmm.
Yeah.
Okay. Thank you.
well, that's
Thank you.
all. This combination, no, it has only, it doesn't even have 50 milligram tramadol in it, 37 only.
Yes, ma'am.
So
30.
you
Yeah.
have to, so minimum TDS or QDS. And see, then other management also, no, you could have had IFT. There are so many options. Non-pharmacological management options, plenty are there for these type of post-viral arthritis. Then nothing
What
of that sort was suggested. First, as Parul said, really sorry. And
Okay.
one way, nice to hear that you got over it also. See, as
Yes.
viral, they will all are self-limiting also.
Hmm.
So all our basics, what we study, have to be remembered. Okay, and then these doses, that's why I said, even in renal, no, you have to keep an eye on everything. See, we have got facilities, patient is the best guide, what response they are getting. So based on that, just a BD dose alone, not enough. So, and you said only few, that's why even in the assessment, what did Dr. Khanna said that day, each time you take the medicine, for how many hours you get relief. That is what you have to ask. So that gives you an idea. And that's why assess, reassess, review, reassess. Keep on doing that to have a better outcome or benefit for the patient. So that's all. Dosage, other alternative managements, what could have been used, non-pharmacological management, and using the NSAIDs for SOS. See, those NSAIDs, even if someone has very bad thing, use it for very short pulses. NSAIDs are very good if they are used appropriately. You can use as
What about
pulsed like once.
corticosteroids, ma'am?
Hmm?
What about
Not required.
corticosteroids? Not required. Okay.
Not required for this.
This. Okay.
When you've got so many, no, why jump
Other
to something
options.
which has got
Okay.
more? See, your dosage, correct alternative with the NSAID as and when required, when it is very bad alone. And if you'd have used non-pharmacological also together, your need of all this would have come down. You might not have even needed the rest. See, it is multifactorial. There's one. Okay. So as Parul has answered, no, initially you have to see the patient few times. Like if they can't come, phone review. Okay, you assess, reassess, make sure they are settling with the medicine, getting the benefit. First 1 week or 2 weeks, you have to have 48 hours. Make sure that they're getting the benefit and they are on the right track until then. And then continue after 15 days or something like that, based on their response and their need. Telephone review may work if they are coming from far or something like Okay. Any other burning question? Or else I will hand it over to Sangeet. And a big thank you to you, Parul.
Hello, ma'am.
Thank you. Thank
Uh,
you.
Yeah,
Is
this
somebody
might
asked?
be so I'm Abdul Hassan. So as we saw on the slide, there was an initial slide that showed believe in the patient, and I think that should be emphasized. But there are some rare situations where we encounter patients with malingering. I know this is a tricky question, and how do we handle? And are there any ways to identify those patients who may be like acting acting their pain or like exacerbating their actual pain? How do we identify those?
So
While
any
seeing
kind
them,
of
reviewing them. Go ahead, Parul. Go ahead. You go ahead, Parul,
the
first.
patient is having, if you believe, malingering or exaggeration. There's the one thing which I remember, which I remember Rajgopal sir said once in his session. If you feel that patient is exaggerating or malingering, you have to remember there is some kind of psychological pain. So you have to really assess the patient. Really assess the patient before concluding that patient is just for the sake malingering. Even that is also a psychological pain that we need to address.
Okay.
Well said, Parul. Exactly, Dr. Amara. As we have got someone who is the key person. So yes, that's what total pain assessment. And then with malingering patients, many times you will know that they will be coming for what to say, it won't be proportional.
Okay.
Okay, but if you assess the psychological component and deal with it, that also is part of total pain care, no? So that is the most best way to take. And someone you've answered for that B6, B12. So that is all. That's why you have so many things now. No? You correct everything. Correct the correctable.
Okay.
Okay, that's what you hope you have got the answer for it, Dr. Abdul?
Yes, ma'am. Thank you so much. Thank you, Dr. Parul.
Thank you very much. Thank you to one and all. Over to Sangeet.
Thank you, Dr. Parul, for the wonderful presentation. Thank you, Radha ma'am, for the wonderful facilitation and solving all the queries of the participants. Thank you all for joining the sessions. Thank you. Let's see in the next session. Bye.